gland, and then talk about hyperparathyroidism, primary, secondary, tertiary, and familial hypercalcemia, hypocalciuria, parathyroid cancer. And finally, I'm going to shed some light on multiple endocrine neoplasm syndrome or MIN syndrome. And first of all, I'm going to talk about the embryology. The parathyroid gland is developed from endoderm of third and fourth pharyngeal at the sixth the diverticulation each pouch. The inferior parathyroid originates from the third pharyngeal pouch, and the superior from the fourth pharyngeal pouch. Sorry. So now I'm going to talk about the anatomy of the parathyroid gland. There are four pair of glands, which are lie external to the thyroid capsule of the posterior surface of each lobe. Their shape are flat ovoid that resemble a linnet's seed. Their color is yellowish brown, and they are 40-50 milligram for each weight. The location is medial half of the posterior surface of each lobe of the thyroid gland inside its sheath. Now I'm going to talk about the superior and inferior location. Uh, and can you hear me? Okay. As I mentioned, the two superior parathyroid glands are more constant in position and lie at the level of middle of posterior border of thyroid gland, while the two inferior are usually lie close to the inferior pole of thyroid gland, and they may lie within the facial sheath or embedded in the thyroid substances, and sometimes outside the facial sheath. For the supply of the parathyroid gland, their arterial venous supply are the same of the thyroid, superior and inferior thyroid arteries, and superior, middle, and inferior thyroid vein. For the lymphatic drainage is deep cervical lymph node and paratracheal lymph node. For the nerve supply is superior middle cervical sympathetic ganglion. For surgical importance, usually parathyroid, since I mentioned before, it's inconstant location and it can vary widely. Due to this variation, damage to the gland can be occurred during any surgery or especially thyroidectomy. Removal of both pair of parathyroid gland is extremely uncommon and would cause a decrease in the serum calcium level, leading to the development of tetany, cardiac arrhythmia, and a host of other unwanted effects due to hypocalcemia. The relative position of the parathyroid in relation to the recurrent pharyngeal nerve will help us to determine which gland has been lost during surgery. Since the superior gland is lie behind the plane of the nerve, while the inferior gland in front of the nerve. For the physiology, it's like very easy. When there is decrease of serum calcium, This will stimulate the parathyroid gland, which will reduce parathyroid hormone. When it's released, it's going to go to the kidney to activate vitamin D, and also will cause increased calcium reabsorption and when the vitamin D activated, it will go into the intestine and stimulating the releasing of or the absorption of calcium. And also parathyroid hormone will go to the bone and cause bone resorption and increasing, which lead to increasing the calcium level. Does anyone have any question about either the embryology, anatomy, or physiology?
It's clear.
Clear.
Okay. Okay, thank you. Now I'm going to talk about hyperparathyroidism. Okay, alhamdulillah. I will begin with primary hyperparathyroidism. By its name, primary, so it's primary due a problem or abnormality in the parathyroid gland, which will cause increase of parathyroid hormone production. Its incidence is 100,000 cases in USA yearly, and it's usually from 50 to 60 decades, and it's female predominant, unfortunately. Prevalence is 0.1 to 0.3. Etiology, it's vary. It's either unknown or because of ionized radiation, decline renal function, or inherited disorder. For clinical presentation is known as stone, thrown, bone, and groan, and finally psychological overtone. A stone, the patient will either have nephrolysis or nephrocalcinosis. The difference between them is the first one is a renal stone, while the second one, which is calcinosis, is the presence of calcium salts within the kidney. Thrown is polyuria, polydipsia, nocturia. Polyuria due to increasing, yes, polyuria due increasing of calcium level. Polydipsia due to like secondary to polyuria, and nocturia. Bone will patient will have osteopenia, osteoporosis, osteofibrosis, and bone pain. Groin, the patient will have constipation, peptic ulcer, and pancreatitis, all because of increasing of calcium level. And and finally, psychotic overtone. The diagnosis, it's usually since it's the thyroid, so it's not always palpable or thyroid hormone decreases calcium, decreased serum phosphate and elevated chloride phosphate ratio above 33. Its management, it has two management. It's either medically and surgically. Medically, by selective estrogen receptor modifier, which will decrease the effect of parathyroid hormone on the bone, and biphosphonate, it's like a protection of the bone, and calcium mimetics, surgically by removing of the thyroid, which is parathyroidectomy. Secondary, we have secondary hyperthyroidism. By its name, it's secondary to underlying cause. It's either chronic renal failure or hypocalcemia. The patient will be presented with bone pain, muscle weakness, renal osteodystrophy, soft tissue calcification, and psychotic disorder. Renal osteodystrophy is like it's biological, caused by chronic elevation parathyroid hormone, abnormal calcium, phosphate, all level, and which gonna affect the bone turnover. So this is called renal osteodystrophy. Its management, it's also medically or surgically. Medically, low phosphatidate, phosphate binder, adequate intake of calcium and vitamin D, surgically by kidney transplant. Tertiary hyperparathyroidism. Its causes is persistent hyperparathyroidism after renal transplant. The parathyroid gland hyperplasia with autonomous parathyroid production. Its symptom, it's similar to the previous pathological fracture, bone pain, renal stone, peptic ulcer, pancreatitis, and mental state changes. Its treatment is a subtotal or sometimes total parathyroidectomy with autotransplant and upper with autotransplant meaning taking of the like protection of the patient. So does anyone have a question about hyperparathyroidism?
It's clear.
Okay, thank you. Okay. Now I'm going to talk about familiar hypocalciuria and hypercalcemia. Also by its name, it's a rare autosomal dominant condition. It's occur as a result from mutation of calcium syncytin receptor gene. It's mutation of calcium syncytin receptor gene causing decrease of receptor activities. Its incidence is a rare condition and its equally distribution between sex. It doesn't have any true prevalences for now. As I mentioned, it's this receptor, calcium receptor, is mutated, so it's not sensitive. So the parathyroid will think that there is not enough calcium in the body, so it's gonna produce parathyroid hormone a lot. So the patient will have or presented with hyper hyperparathyroidism, which is hypercalcemia and hypocalciuria. The presentation, the patient will present with weakness, polyuria, and polydipsia. For diagnosis, we can like taking a family history and measurement of calcium level in blood and in urine. And the treatment is there is no treatment since it's like running family. So it's either reassurance and education and calcimimetics. Parathyroid cancer, it's first of all, it's caused by mutation of CDC73 gene, which found in upon 70 of cases. You know what is CDC73 gene? What is function?
A tumor suppressor gene.
Yes, that's true. It's a tumor suppression gene. So any mutation in this gene will not cause any suppression of cancer. Its incidence is one of the rarest type of cancer. Its incidence is 0.005% of all cancer. It's presented with elevated serum parathyroid hormone and its sign and symptom. It's diagnosed by family history ultrasound to the Its management is by radical resection resection removal of the involved gland and ipsilateral thyroid loop, isthmus, and regional lymph node. Finally, I'm going to talk about Men's syndrome. Men's syndrome, it's autosomal dominant. It's a derived from ABUD cells. It's vary of symptom, have a vary of symptom. It's not curable, it's manageable. Men classified depending on gene mutation. And this is the classification. Men one, which will have pituitary adenoma, it's all P, parathyroid hyperplasia, and pancreatic tumor. Men 2A, will the patient will have risk of parathyroid hyperplasia, medullary thyroid carcinoma, and pheochromocytoma. Men 2B, the patient will have mucosal neuroma, morphonoid body habits, medullary thyroid carcinoma, and pheochromocytoma. The diagnosis, genetic testing in affected family, hormone level in the blood and urine, and sometimes imaging tests to determine where is the tumor or the primary tumor. So to sum up, I previously talked about embryology of parathyroid gland, its anatomy, physiology, and the effect of parathyroid hormone in the body. Then I talk about hyperparathyroidism, uh, familiar hypercalcemia and hypocalcinuria, Min syndrome, and parathyroid cancer. Does anyone have any question?
Thank you. It's clear.
These are my resources, and thank you.
Thank you. Just regarding the anatomy of the parathyroid gland, we have to make our mind know main blood supply to the parathyroid gland is inferior thyroid artery. طيب. Sometimes it will have collateral supply from superior, لكن المين blood supply للباراثيرويد gland are inferior parathyroid artery. ممكن يجيكم سؤال فالinferior parathyroid artery هو the main blood supply. Inferior thyroid artery are the main supply for the parathyroid. Sometimes patient have variant to have collateral supply from superior. يعطيك العافية رهف.